Thank you very much. Again, Manos and Manos for having me. Do we arrow to advance? So I do have a disclosure. Shout out to my mentor, J.P. Warner, who I believe is here. I was exposed to value and innovation in my fellowship, and that inspired me to go down a 10-year rabbit hole of value, and ended up coming out the other side, founding a company based on these concepts. I'm going to tell you that the Transosseous cuff repair is the Bitcoin standard. There's evidence right now in the literature to demonstrate effective cost, superior biology, equivalent or superior biomechanics, superior pain, superior revision considerations, equivalent or superior outcomes, and excellent synergies with fixators. I say Bitcoin because the gold standard was taken to a fiat currency, which is a variable truth, and we're coming back to the realization that we need a hard currency. So this has stood the test of time with all of these giants of shoulder surgery having used it in the past. And another giant, Steve Burkhart, anchor maven, was into this technique as well. And here's his patent from 1997 where he states that there's a value problem, there's a fixation point problem with inert material. Here's his force vector showing that it reduces the cuff better than anchors, better than the dead man angle. And here's his transosseous subaxillary nerve portal that he did a series on years ago, like 20 years ago. The Harvard Business School definition of value is outcome over cost per episode. We're getting bundled payments here in the States. You guys have had single payer systems for forever, and so we all know that this is around, it's not going away. Simultaneously, there's technological convergence and commoditization of all of our anchor hardware. So if we can offer non-inferior outcome and cost effectiveness, we have an opportunity for value. Dr. Codman, one of the fathers of shoulder surgery, who is the father of value and evidence-based medicine, was doing this with Transosseously back at Mass General 100 years ago. He was a stringent critic of his colleagues, and for that he was ostracized and ended up dying a penniless pauper in an unmarked grave. So such are the risks of espousing value. Perhaps he could have done better with that if he had more diplomacy. But if you look at these stern-looking board members on the right side of the cartoon, it could be that they weren't really ready to receive that message at the time. And I would advise that the thought leaders read this book, this classic Structure of Scientific Revolutions, where Kuhn lays out how many great ideas were completely missed by the scientific community because of psychosocial, political, and economic factors. Christian Gerber said, if two techniques offer equal results, the less costly option should be used. I thought this was relatively self-evident, somewhat naively. Most of our techniques plateau. They hit an asymptote when it comes to outcomes. And so with knowledge and perhaps new techniques, we can actually move this backwards. And Gerber actually calls out in Rockwood and Madsen 2021 the opportunity to move this backwards and actually go up and to the left. This is extremely difficult, and this doesn't come around maybe once in a lifetime. If anyone in the audience knows of any other opportunity to do this, please let me know. But I think this is an excellent opportunity. As someone mentioned before, we do have this problem of it's difficult to get someone to understand something when their salary depends on not understanding it. So this is where most of the industry, not all, but most of the industry is in the States, and many of our thought leaders are. But I think hopefully we can get through that with some education. The work of Dirk Stingel has shown that many of our sacred cows interventions, don't move the needle as much as we like to think if you look at them objectively. So non-inferiority and equivalence will become the more important and achievable findings, and it's going to become increasingly difficult to justify paying more for perceived benefits. We show this concept here of a paradigm maturing, shown here with tibia fractures. As it matures down and we get down to locking and non-locking bolts here, it becomes increasingly difficult to actually show differences. And it's my opinion that this is where ankles and tunnels are now. Throughout history, there's been incredibly competent people pursuing this goal. Fliege, Krishnan, Burks, Tadjin, Abood. It's like a who's who of shoulder surgery trying to do these things. And why is that? because of this, and I can't believe Castagna figured this out like 20 years ago, but it's because of this. This transosseous cerclage effect is what we're chasing. It's the most efficient way to reproduce the anatomy of the tendon. And so we've moved through mini-open transosseous to mini-open with anchors. And then when we came to the single row anchor, this is where we failed. This is where the failure increased. Yamaguchi, Bishop showed that. And for about 10 years, the results were actually quite, were worse. And it took the industry 10 years to catch back up by adding a lot of extra costs, adding type 2 failures, adding bone voids and pullouts and inert material in the healing zone with this transosseous equivalent technique. Interestingly, the market is subconsciously or implicitly coming back around to suture, implicitly saying, I don't want the hardware, I don't need the complications of the hardware. And topographically, if you look at a suture, an all suture anchor is a suture with a knot tied in it. And if you believe that a suture with a knot tied in it will fix on the cortex, then you should implant your suture first, tie your knot afterwards, and then you get twice the biomechanical efficiency with a double row. And so I've been trying to do work on the hybrid technique to warm people up to this idea of stepping into this all suture techniques, plus or minus augmentation, because they're not mutually exclusive, and then coming back to full transosseous in many cases. So what is our ideal repair? Well, we want high initial fixation strength and ultimate encyclic failure. We want to prevent gap formation and neutralize shear forces, and I think we're doing that. We want to restore the footprint, as this Korean paper shows. It takes about 6 anchors to really not have bird beaks and dog ears and all these deformities, and that's a lack of fixation points, so we can address that now. We want to avoid these big bone defects. We specifically want to avoid this increased stress riser at the medial row, which causes this anchor-induced failure mode, the type 2 failure mode, which is catastrophic and causes difficulty and expensive revisions. And we want good outcomes, of course, which we're having, and Shukumaran has shown that with ultrasound control. So I think we're doing that with these modern techniques. This is a double box hybrid, and massive tear, nothing in the healing zone, and excellent fixation with independent backup. So I think we're essentially within striking distance, if not doing these already. I would like to suggest some new ideals. Look at this tendon on MRI. It's very homogeneous, and sometimes the radiologist can't even tell it's been repaired. That's sort of that's the golden ring of the transosseous surgeon, when the radiologist can't even tell you fixed it. But there's excellent biology, and the MRI characteristics are excellent, and we should look at this biology and healing. We want to be able to use our biologics under a cost ceiling and do our SCRs with less hardware cost, and advance the field of shoulder surgery into the future with biologics that are actually able to be used because they're cost effective. If you believe blood flow is necessary for healing, then there's almost 3 times blood flow increase with transosseous. That's been shown by the Japanese. We need to be cognizant of the blood flow and being gentle to the tissues. And this problem of the stress gradient, transosseous seems to be fundamentally different, and it eliminates the stress riser and that type 2 failure. And I would like to tender the idea of true load sharing and multi-fixation point. So instead of having a impulse loading at 2 small nails like you have with like a speed bridge, you want multiple fixation points to reduce that stress on the tendon. We can have novel concepts with synergistic techniques using anchors and tunnels together. They're not mutually exclusive. We want time equivalence, and this has been shown by Lazarus and Black in the OR, and we want cost efficacy, which has been shown as well in the literature already. The authors of the transosseous equivalent technique specifically say in their paper they're trying to do what transosseous does. And they specifically say that placing anchors on top of the healing surface reduces potential for healing. And so I agree. So that's exactly why we go to transosseous. Hybrids have been described back in the early 2000s. This is one of the first ones I did, so I just copied this one from the literature. Very high failure, 400 to 500 newtons. And this is a big optimization problem. So some surgeons want time, some people want lower cost, others want high fixation strength. And transosseous gives you the ability to do and solve that equation in your system with your hands and do what you want to optimize that equation for yourself. This is an under-publicized study that I'd like to call out. On the right is Brian Cole's slide from the ESH meeting showing transosseous equivalent ultimate tensile strength reaches about 350 to 400 newtons. Gus Mazzacca and Bernie Bach published this multi-suture technique years ago, and if you look at the left, 856 newtons was their median failure mode. That supersedes the natural tendon at 790, and their maximums were 1100. They were ripping off the surgical neck of the proximal humerus using all suture. So it's all about the suture. And when we can do these kinds of cargo net type constructs, we're within striking distance of that. Biomechanics, you can find pretty much anything you want to find in the literature, but I think it needs a lot more study. Fundamentally, we don't understand fully the stress responses here in the microenvironment, but there's a fundamental difference in the loading mechanism here. Rodeo and Jost showed us, we were arguing about single row and double row and couldn't show a difference, and no one was controlling for the number of sutures. So it's all about the number of sutures that you have in there. It's not about the anchors. And so again, now that we can implant tons of suture, we can essentially achieve whatever amount of newtons you want. I would like to suggest to the thought leaders present that rows are becoming an outmoded way of thinking of these things, or that's an in-the-box way of thinking. I prefer, fixation point density per surface area or numbers of sutures per fixation point, which is the real sort of basic principles way of looking at it from a physics standpoint. So we can put tons of sutures in, and one of the ways to deal with soft bone is to have multiple sutures in there sharing load. So let's go to the soft bone. This is one of the biggest questions and perceived disadvantages. If you look at the nomogram, soft bone starts about 70. So first of all, just by indications, there's a ton of cuff repairs between 40 and 70 that are probably not that much of an issue. So when you have if you look at a Gaussian distribution of bone mineral density, you would say, all fixation works on the high end, so it's dealer's choice there. Now on the low end, everything fails, so you probably want to use sutures to not cause complications. And maybe there's some room for hybrid or augmentation in between. It could be subject to debate. So when you critically look at the behavior of anchors and tunnels in soft bone, what does a suture do? It pretty much cuts through laterally, but it still attaches to the tendon, and it still has a reduction vector on the tendon. What do medial row anchors do? Well, they pull out under your cuff repair and create a huge bone void. That's a bad day. Laterally, they cut through superiorly, like this one did, and I fail to see how that helps you. That creates a harder problem. It makes a larger hole. It floats free as a loose body. Everybody knows it's an open secret that anchors never dissolve like they were intended to. It decreases venous outflow. It increases intraosseous pressure. So, there's a lot of problems there. Here's one with super soft bone that I'll show you as an example. So that's an 8 to 10 millimeter defect. An anchor would not fit there. And I think the solution to medial bone loss is transosseous. It's not the problem, it's the solution, because you can fix that laterally. That's a hybrid. Here's one, Bassam asked about this earlier. Here's one that we did with a hybrid technique with an ACL button. That's like a Gerber 1988 sort of technique, and we did that arthroscopically, and that worked great. That guy fell after surgery and tested the construct, and it held. He actually fractured the tuberosity a little bit, but it held. So there's more than one way to to skin this cat. And trying to advance. So we have all of these options on the right for rotator cuff, but I think we need to apply the same critical thinking towards the bone problem. The advent of the reverse has changed us a lot because the butter bone 80-year-old irreparable cuff tear just gets a reverse now. So, that catastrophic cut through, we don't really experience that as much anymore. And even using density is a surrogate, and that's necessary but insufficient. You can X-ray a sandbox and it looks dense, but it won't hold a screw, which is what you really want to know. So I think we need to work a little bit more on the differences in bone quality and the heterogeneity of bone in local proximal humerus. So this is the true transosseous hybrid technique that we developed to answer some of these questions. The most common problems from the field are cortical augmentation for weak bone and knot tying. So what this does is allows you to have independent fixation. So instead of hanging your whole construct on a knotless anchor, and then if that falls apart, if that fails, everything falls apart, you have independent transosseous fixation, and then you could augment the cortex with a knotless anchor, and you get a chance at tensioning. It's a triple row construct. As well, and this is what it looks like. So it kind of looks like a transosseous equivalent, but there's no inert material in the healing zone, and you can get quite robust constructs with this technique. This is my pilot study from the original device, 143 patients at 14 months follow-up. We had a 4 to 5% re-tear with excellent ASEA scores at 92. And to the right is my SOS data with 500 patients in that database landing around 90. We've discussed this as well. Shrukumaran has shown equivalence in anchors and transosseous with ultrasound control. This level 1 Turkish study has shown this. This is hot off the press, 2020. Platchel and Resch have shown 12 to 18-year follow-up using a device that doesn't exist anymore. Excellent results with ASES of 92, so very similar to mine. Kuroda has this interesting repair from Japan with 384 cases and 6% re-tear, and interestingly 3% with absorbable. So maybe we shouldn't be using these. Maybe the next trend will be we won't be using non-absorbable sutures anymore. To my knowledge, this is the longest cuff follow-up in the literature. Philippe Collin, Christian Gerber, Gilles Valche, 20-year follow-up. If you read the fine print, it's transosseous repairs. So I think this is the best follow-up we can get, and it's again favors transosseous, 10% reoperation. I'll show you a quick technique of how we do it. So we're clearing out the bursa here from the outside. We use a small 7 to 8 millimeter portal. We come in inverted and pop through the subdeltoid fascia in an inverted fashion, rotate through the portal, find the medial hole that we've created there, and then we're going to translate down and then rotate inferiorly to get the good bone bridge. And then once we're in place, we'll go ahead and we don't drill, we compact the tunnels to increase their strength theoretically, and simultaneously deliver and capture the suture very quickly and efficiently, and then we pull it out. So it's very quick to make the tunnel. At this phase, you could proceed with a racking hitch or some of the other loop techniques we've talked about already. I usually will manage this through the superior portal and then use a triplet, 3 sutures, 3 tapes, which is a good balance of speed and strength. So we pull that down, and then here's a little trick for suture management. We have colored suture organizers, and we snap this down to the Coban in static mode, so that does not slide, so it becomes just like an anchor repair. And then we're going to snap it in dynamic mode up to the drapes, and then it'll be just like an anchor repair when you start working on that. And it's topographic management, so what's happening on the outside is happening on the inside as well. So here's what it looks like from the inside. And I won't go through the whole thing, but I'll just show you these sutures. We exclude the sutures with the cannula. So we put them on the outside of the cannula, and now it's a lot easier, and you're actually picking up time in the repair because you're passing simple sutures instead of mattress sutures, and then you just tie 1 knot. So that's actually why it's time equivalent, one of the reasons. And this is a fascinating point. There's a level 1 evidence out of Italy that shows that there's significantly decreased pain. And we hear this a lot from adopters who, as they go from anchors to transosseous, their therapist will say there's much less pain. And you can see this MRI on the right, that was read as a negative cuff tear. And there are the arthroscopic pictures of the repair. So it's a little bit biologically more friendly. And why this is, we're not quite sure, but we hypothesize that there's increased pressure in bone is associated with pain. When you place an anchor with a diameter mismatch, you're causing plastic deformation and fracture physiology that causes bone marrow edema and increased pressure for 6 months. And this could be one of the major pain generators that could be hurting us with our opioid-sparing cuff techniques. So again, transosseous really helps us in that regard. Here's some emerging techniques with biceps. We showed that, but this cerclage effect is very powerful in bone. It's also very powerful for soft tissue.
Dr. Sanders, I'm sorry to interrupt, but we were told to tell you that the time is running out.
Okay, fair enough. Thank you. I'll quickly end here. This is a long head of biceps, supracapsular reconstruction, and other advanced techniques with allografts are in development for consideration in the future. Thank you.